All right, good morning, everybody. Again, Josh Burton here. Moving forward through the cardiovascular lectures on the COMAT EM review series. All right, let's go. Next topic, aortic dissection. Let's start off with a question stem here. 55-year-old male and presents to the emergency department with chest pain. Pain with sudden onset, radiates to his back, described as a severe tearing pain. Vital signs reveal blood pressure elevated 190/100. Heart rate is 95 beats per minute. Patient has 2+ pulses to bilateral upper extremities, no palpable pulses to the lower extremities. Which imaging modality is best used to evaluate this patient? Obviously, this question stem has loads of information and clues pointing towards an aortic dissection, which we'll talk about as the lecture progresses. But just a brief review here. So 55-year-old male, sudden onset chest pain, radiates the appropriate area to the back. They're hypertensive. He has pulse deficits. Best imaging choice to choose. That's correct. CT angiography of the chest and abdomen. Nice job. All right, let's dive in. Epidemiology. So this presentation will be most common in males age 50 to 70 years old. Keep in mind, this is going to be a review lecture. Aortic dissection can happen in all ages, and that's for a different discussion. But for here, we're going to keep it basic so you guys can get the answers right on the test. So clue in, male 50 to 70 years old. Most common predisposing factor for an aortic dissection is hypertension, which will make sense when we talk about the treatment. Other risk factors that they might throw in there for you will be like connective tissue disorders, pregnancy, trauma, something to that effect. Pathophysiology, sometimes this will sneak into the test. So you'll have like an intimal tear that allows blood to then enter into the media or between the intima and the media there, and then it starts dissecting either up or down, depending on what type of dissection we're talking about. Typically, it's high blood pressure. You get rapid ventricular contractions, and each time that heart beats, you enhance the migration of the dissection, or it progresses down. So, to describe the aortic dissection, there's different criteria that's been used. One of them is the DeBakey, and the other one is the Stanford criteria. I've seen questions on both of them, and so it's good to be familiar with them. Choose which one you want to memorize, and it should work out okay. We'll start on the left and move our way over. So this one right here is DeBakey type 1. Easy on this one. If you think it's the first one, it's going to be the worst one. So it has both the ascending and the descending aorta involved, and it initiates in the ascending area there. The next one is DeBakey type 2. In the picture here, it's just the ascending aorta that gets involved. Then you move down to DeBakey type 3, and there's an A and a B, and the differentiating factor is your diaphragm. So they're both including the descending aorta. One will stop above the diaphragm, and one will go below the diaphragm. This is probably the more complicated definition or criteria of aortic dissection, which is why I typically like to memorize the Stanford criteria, which is really just type A for ascending, and B for descending. Lots easier to remember, and that will come important later when we talk about treatment as far as how we treat ascending dissections versus how we treat descending dissections. You might get a picture on the exam. So here you have a Stanford type A dissection here at the ascending aorta, and here on type B, the descending aorta through here. How do these patients typically present? So again, kind of going back to our question stem, it'll be a sudden onset of pain. It will typically use like the descriptors of tearing or ripping chest pain. It'll radiate to the back. Chest pain is the most common symptom, and so you might get an answer or a question stem that says, what's the most common symptom of an aortic dissection? It'll have chest pain, dyspnea, syncope, something to that effect, and chest pain is the most common. When you think of an aortic dissection, you always think of chest pain and something else. And that's what kind of clues you more into a dissection and maybe a little away from like myocardial infarction or a pulmonary embolism, something else. And so with an aortic dissection, chest pain plus, did they pass that? Is this chest pain and syncope? Is this chest pain and my left arm is weaker than my right? Chest pain that started, in my chest and has now progressed down into my abdomen, and we're feeling the dissection going down into the abdominal cavity. Something to that effect clues you in on how they're trying to get at an aortic dissection. Typically what you see is chest pain and a neurologic finding. So keep in mind, if the dissection is ascending and it takes off the branches off the aortic arch, well, that's usually why these patients present as a stroke. And so look for clues like that that makes you think, this might be a dissection, not so much a stroke. On physical exam, you'll typically have like the difference in blood pressures. So they typically should have high blood pressure. And then you're looking for a difference of 20 millimeters of mercury between two different blood pressures. You're looking for focal neurologic deficits. Pulse deficits seems to be a common one to clue you in. And so they have a pulse on their left radial, but they don't have it on their right. They have pulses in the uppers, but not in the lower extremities. The other one is that if they can describe, a 50-year-old male, sudden onset chest pain, no past medical history, now has a new diastolic murmur on exam, and you think of like an ascending dissection that's gone into the aorta or into the valve, and it's caused an aortic regurgitation murmur. Another example would be if it's an ascending that goes into the pericardial space and you get cardiac tamponade, and then you get presented with like a Beck's triad or something, and they have JVD and they have muffled heart sounds and they're hypotensive, then you're thinking cardiac tamponade as a cause of or stemming from an aortic dissection. And they might clue you in, give you an ultrasound finding, and you see all this blood around the heart, saying that this is a cardiac tamponade. Aortic dissections can also go into the coronary arteries, and you most commonly can present as an inferior Stemi. Super difficult to probably to differentiate between, is this a heart attack, coronary syndrome, is this a heart attack, aortic dissection. But, if there's a question that says, aortic dissection can commonly present, what kind of, STEMI mimic or something to that effect, it's an inferior STEMI is what they're looking for, and it goes into that right coronary artery. How do you diagnose it? So typically you'll have the chest x-ray either on the question sim or a part of the workup there, and everyone always knows it's a wide and mediastinum. If you're looking for the definition, it's more than 8 centimeters wide is what you're looking for. So again, right through here. And on this one, you can almost see like that cardiac, or the contour of the aorta kind of coming up and coming down, and it is definitely wide. There's a lot, there's more chest x-ray findings, but that's typically the most common that you'll probably run into on a question sim. The one you really want to know is diagnostic test of choice, and that's a CT angiography, right? So we're going to throw the dye into the aorta, we're going to follow it all the way down, and looking for that tear to clue us in on the aortic dissection, make the diagnosis, and then determine, hey, is this ascending, descending, and who we're going to call. Management. So a couple questions you might see is, they'll give you a slam dunk aortic dissection presentation, and they can make them unstable or whatever it may be, and you're like, man, I really think this is an aortic dissection, and they're going to ask, what's the initial step you're going to do, and it could be, start IV esmolol, it could be go to the CT scan, something to that effect. And if it's high suspicion, if there's enough in the question stem that says, man, this is an aortic dissection and things are getting worse, you want to begin treatment immediately and don't delay for the study results. And so step one is beta blocker therapy, right? So going back to the pathophysiology, every time that heart contracts, it's propagating that dissection down. So we want to slow that down as much as we can. IV esmolol, IV labetalol, propranolol, whatever I mean, but you want an IV beta blocker that you can titrate and slow down that heart rate. That will typically bring the blood pressure down as well. If it doesn't, step 2 is vasodilator therapy. So you're looking at nitroprusside, nicardipine, clevedipine as a second agent to go after the beta blockers. Real important. Beta blocker first, vasodilator second. Goals of therapy, you're looking for a heart rate of anywhere 60 to 80 beats per minute and a systolic between 100 and 110. Other than that, that's about all as far as management goes. If it is a ascending dissection, typically those are done surgically. If it is a descending dissection, typically that is done medically. And so that's kind of how that differentiates as far as why we understand or why we remember the different classifications of an aortic dissection. Let's do some review questions and hone in on some of these key points. So number 1, which of the following is the most common predisposing risk factor of an aortic dissection? Tobacco abuse, definitely a risk factor. Connective tissue disorder, hypertension, family history, absolutely. The one we want to key in on is hypertension, and that's why we're treating the way we do. Next one, kind of going back to the original question, Sam. So 50-year-old male presents to the emergency department with chest pain, sudden in onset, radiates to his back. It's described as a severe tearing pain. Blood pressure is 190/100, heart rate's 95. He has pulse deficits. What medication should be initiated first? So again, we're looking for a beta blocker therapy first, then we're looking for a vasodilator second. So on this one, esmolol is what we're looking for. Okay. Same presentation. So 55-year-old male presents to the emergency department with a chest pain. It's the same question, Sam. Going to the end here. Prior to CT imaging, patient enters PEA arrest. What is the likely cause of this patient's demise? Hypovolemia, tamponade, tension pneumothorax, hyperkalemia. All of those would cause a PEA arrest. But given the situation, we're thinking cardiac tamponade based on that question, Sam. All right, guys, that's all for aortic dissection. Thanks.